Be go.
Perfect. You could see the slides okay?
Yeah, we're great.
Perfect. So I'm going to be talking a little bit today about, we're going to start with some basic pulmonary issues, and then we'll get into some different kinds of chest trauma that we might see on the sideline. So some objectives today, we're going to recognize some common pulmonary conditions in not only athletes, but adults. We'll try to identify some life-threatening chest trauma, and different ways to treat it. We'll review some sideline and clinic management for those injuries and different other pulmonary conditions. And then we'll kind of talk about some basic return to play decisions when it comes to these issues. So why does this matter? I think just, being in training room this year, we've seen that there's not only respiratory complaints related to sports, but also related to just basic medical conditions and chronic issues that some of the athletes have. So these are all very common. And then as far as being on the sideline, chest trauma, it is common, obviously depending on what sport you cover, hockey, football, even lacrosse, and even wrestling can sometimes have higher frequency of chest trauma. And it could for sure obviously be high risk. Um, Anything involving the heart, the lungs, obviously vital organs that play a big role in living. So missing these diagnoses can lead to serious morbidity and mortality. And then decisions we make on the sideline can be life-saving and often are time specific when it comes to these injuries. So this is just an opening case. Fortunately, Kelsey, our Steelers fan, isn't here to see this lovely hit and be remembered of it. But this is a case that we'll kind of touch on at the end of this talk. But I'll just leave it here for now. So, 18-year-old football athlete with a history of asthma experiences a helmet to chest collision. Initially, they're able to walk off the field with no acute issues, and then after 5 minutes, they start to develop increasing shortness of breath and ultimately collapse. So I just want you guys all to think about what would you do in this situation? What kind of things are you initially thinking of? What kind of resources, what kind of people do you want? Um, and what kind of things would you do next? So I'm going to kind of divide this talk into two categories. The first will be pulmonary conditions, including asthma, bronchoconstriction, laryngeal obstruction, infection, spontaneous pneumothorax, pulmonary embolism, and then we'll get into some different kind of traumatic issues, rib fractures, contusions, pulmonary contusions, pneumothorax, pericardial effusions, and commotio cordis. We'll kind of talk about different ways to treat all these conditions. So first, we'll get into some pulmonary conditions. Of course, can't talk about the lungs without talking about asthma. Probably the most common chronic airway disease we see. Literature describes it as 8 to 10% of adults in the US have some form of asthma. It is a disease with different genetic and environmental influences that leads to airway inflammation, bronchoconstriction, and increased mucus productions. Symptoms often include a cough, a wheeze, and shortness of breath. And there are many common triggers, especially living here in Cleveland in the cold weather. Um, Different viral illnesses can trigger an asthma exacerbation. Just living in the cold and having poor air quality can trigger it. Smoking, being someone who smokes or being around people that smoke, whether that's someone you live with, a parent, or being in an environment with smoke, whether you're at a bar or at a restaurant or casino, somewhere that allows smoking, and then being exposed to different allergens. So whether that's something in the environment, like springtime allergies of different kinds of trees and pollen or grass, or being exposed to something as simple as a strong cleaning solution that you inhale and can get into your lungs and irritate it. All of those can kind of trigger asthma and lead to a exacerbation or worsening of the patient's chronic asthma. So diagnosing asthma, probably not something we're going to do in the training room or even in the clinic. And usually by the time the athletes get to a high school or college, or even the pros, they'll already have been diagnosed with asthma and been dealing with it since they were a child. Um, but often, spirometry and pulmonary function tests are the mainstay of diagnoses, typically done by a pulmonologist or ordered by a primary care physician. Um, and seeing the patient's response to bronchodilators is one of the things that helps kind of differentiate and diagnose asthma. Um, I'm sure we all remember these curves from med school, seeing the differences between normal lung pathology when it comes to pulmonary function tests, and then differentiating into obstructive and restrictive defects. So obstructive, the main thing is that they're able to inspire normally, but they have difficulty expiring or getting all the air out of their lungs. And that is why asthma is the mainstay of treatment is bronchodilation to kind of help open up the lungs to help the patient expire. So this is kind of a busy slide, but it does go through some of the more common asthma medication classes that you'll frequently see patients on. So in regards to on the left, it kind of goes through the different classes. Um, all of these letters stand for something. So ICS is inhaled corticosteroids. SABA and LABA are short and long acting beta agonists. And then there is combination of those. That those top four groups are probably the way most common medications you'll see. Budesonide, fluticasone, albuterol, levoalbuterol are by and away the most common medications. So the inhaled corticosteroids are the first line controller therapy, and then the SABAs, the class of albuterol, those are the kind of quick symptom relief medications that will be a quick bronchodilation for the patient. And then on the right, it does go through some of the side effects or adverse effects of the medication. So with any of the steroids, you can develop oral thrush. And then very frequently, you'll see with the albuterols, you'll get a tremor and tachycardia, especially with multiple repeated doses. When I work in the ER, I often see patients will kind of develop tachycardia after getting multiple doses for a asthma exacerbation. And then the ICS and LABA combinations, those are becoming more popular. Those are your like Rovanas. That is a combination medication that is used for kind of maintenance controller therapy. It's commonly used in the SMART therapy, which is just a one medication or one inhaler that you need to take. Um, it stands for single maintenance and reliever therapy. And then the llamas, the LTRAs, these are sometimes used, but not as common. Um, and then we all know our friend, the oral corticosteroids. So prednisone, solumedrol, methylprednisolone, dose packs. Those are used for kind of acute exacerbations and reserved for patients that maybe just need a little bit of extra anti-inflammatory effect. But we all know systemic steroids can have multiple adverse effects, especially when used for prolonged periods of time. They can sometimes make patients have insomnia, be extra hungry. Some people like it gives them more energy, it makes them feel great. And then when it kind of wears off, they're like, oh, I guess those steroids were making me feel better. And becoming more common is these biologic agents or immunomodulators. One of the common ones I put on here that I've seen a lot of commercials of and seen a lot more patients on is Dupixent. It is like a injectable, I believe it's once a week, used for severe asthma or for other like severe allergy issues, and even some autoimmune issues too. So this is kind of the stepwise approach to different treatments for asthma. So starting on the top is more the kind of intermittent symptoms, someone who has um, not symptoms every day, but maybe once a week or maybe once or twice a month. Um, they can use an ICS LABA combination, that's your Bovana or your Symbicort, um, every day. And that's preferred generally for patient compliance because it's a one medication, um, and it's preferred over the SABA, which is the short acting, the albuterols. because it has lower exacerbation risk because they are getting some of that inhaled steroid. And then as you kind of go up into the more mild persistent asthma and moderate persistent asthma, you're still on that low dose ICS LABA, but then you could start adding in other medications like montelukast or formoterol. And then once you get into the severe asthma, you start to increase into high dose medications and then add on even more medications such as the biologics or montelukast or any of the leukotriene receptor agonists. I would say if you're starting to get into that category, they probably need to follow with a pulmonologist who will, number one, prescribe it and then kind of monitor them and see their response to those treatments. So as far as exacerbations, anytime someone comes in with, worsening asthma symptoms, this is something to consider. And these are different treatment options that you could add on to their already, normal regimen. So as far as differentiating mild, moderate, and severe, I would say probably mild and moderate, you can probably manage in a, clinic, training room setting if you feel comfortable. Severe and then obviously life-threatening probably needs to go to a hospital for at least monitoring for a few hours and then plus or minus be admitted. So mild to moderate, you're just going to increase their dose or their frequency of using albuterol and then consider putting them on some sort of systemic steroid. So I like to use prednisone for 5 days. I just feel like it is something that's easy for the patient to understand. Taking one pill once a day for 5 days is something that hopefully is straightforward, whereas sometimes the patients can get a little confused with the Medrol dose pack. So I would prefer patients be on prednisone just for compliance. And then as far as their albuterol, I usually tell them, every 4 to 6 hours, you could do 2 puffs. If it's anything more than that, probably need to consider going to the ER. Um, for these severe exacerbations, some kind of risk factors that will tell you that maybe they are having a severe exacerbation or need to be considered to go to the hospital. If they've ever been admitted for asthma before, ever been in the ICU, ever been intubated, those are all real big red flags that say, hey, this patient probably should get some eyes on them and be monitored, with the cardiac monitor, with a pulse ox, while they're getting treatments and for a few hours at least, and see kind of how they respond to treatment. So those severe exacerbations will get frequent short-acting beta agonists with albuterol, niprotropium. So that combination in the ER, we call it a duoneb. We'll usually give them 3 right off the bat to see how they do, as well as give them systemic corticosteroids, whether it's IV solumedrol or oral prednisone, or even sometimes decadron, especially in the pediatric population, and then give them supplemental oxygen if they need it. And then after that, we talk about more life-threatening asthma exacerbations, and these can get real scary real quick if they don't respond to that initial treatment. IV magnesium is something that we will give them that gives a little bit more of a bronchodilatory effect. Sometimes even ketamine will kind of calm them down if you think there is a slight anxiety component to the tachypnea and worsening shortness of breath. Not at a full dose that will put them to sleep, but just more of like a pain dose that will kind of make them calm down and help them breathe better. And then always you got to prepare for intubation. You got to prepare for the worst case in the ER and make sure that you're ready to act if they get worse. So this is a typical X-ray you will see where someone for asthma just really shows hyperventilation of the lungs. People kind of debate whether or not you need a chest X-ray for an asthma exacerbation. I would say if there's any concern for another process going on that's leading to worsening shortness of breath, whether that's pneumonia, whether that's a pleural effusion, pulmonary edema, for sure get a chest X-ray. If they're not getting better after treatment, I would say always better to get an X-ray to make sure you're not missing any of those other diagnoses that can be also contributing to their shortness of breath. But this X-ray here looks pretty normal just for classic asthma, nothing that you would need to alter treatment for. So kind of in the I guess like the cousin to asthma or related to asthma is exercise-induced bronchoconstriction. So this is more of your exercise-induced asthma. You know, patients, athletes will say that I have asthma only when I work out or only when I play sports, and this is what that kind of falls into. So up to 10 to 20% of people will have it. More common in the cold weather sports, just kind of getting that cold air that will kind of induce bronchoconstriction, and it can occur with or without um, asthma as a previous diagnosis. Same kind of symptoms as asthma, so sometimes hard to differentiate, but this only occurs when you're exercising. Cough, wheeze, chest tightness. They can even have decreased exercise performance because of this, because they're having trouble breathing. And symptoms will kind of peak immediately after or at the end of exercise, right, as they've kind of exerted themselves the most. Diagnosis is similar to asthma, spirometry, and then have them do spirometry while they're exercising. And treatment is going to be similar to asthma. You're going to give them a short-acting beta agonist like albuterol before or during exercise, and then you can do inhaled steroids if persistent. So one of those ICS inhalers. Um, Always easy to say when you have this diagnosis that it's just not deconditioning, like the patient's not out of shape, but definitely something to think about if they're wheezing or they're really coughing and having issues with exercise. So this is something I hadn't heard of before, but I was reading about it. So it's called exercise-induced laryngeal obstruction. It's often misdiagnosed as asthma, but it's more of an upper airway issue. So this is a laryngeal obstruction. It's higher than the asthma issue, which is inside your lungs. So this is actually your larynx. Um, and symptoms are somewhat similar, but they're often higher up in the throat. So patients will feel throat tightness and they'll have some inspiratory stridor, and they'll have rapid symptom resolution after stopping exercise. Definitely hard to diagnose. The way to diagnose is actually do laryngoscopy during exercise, which is for sure something that you'll have to arrange, and see who does it in your hospital institution. Um, but you actually look down at the larynx during exercise and see if it constricts. Treatment, unfortunately, there's not great treatments for it. There's not like a medication that you can do that will help dilate
That's two
this.
plus 275.
There is often not much you can do. Some of the treatment options are doing speech therapy to kind of help work on controlling those muscles there, but inhalers won't help. So, something to think about, especially if patients aren't getting better with your traditional asthma treatments.
I'm gonna pipe in super fast. So
Sure.
that used to be called vocal cord adduction or vocal cord dysfunction. And we see it a lot, especially if you're on the sidelines of an event. You'll see people coming off and you'll hear them with stridor. You can usually ask people, like, if they're having shortness of breath, like, where do you feel the tightness? And they almost always grab at their throat or neck. Even in clinic, like, they'll be able to remember, oh, yeah, like, and you can ask them, are you having trouble getting air in or air out? And they'll tell you, like, they can't breathe in most of the time. Oh, so you can make the diagnosis clinically. You don't have to send them for laryngoscopy. Um, the hardest part is finding a speech therapist who's willing to treat this. And honestly, if you find a good speech therapist, most people get better in one or two visits. So they are very effective teaching the kids how to coordinate their breathing properly. And then the other diagnostic clue is this is almost always type A, high achieving, high anxiety people who get this. So there's probably some sort of, overlap with, and you can imagine if you feel like your throat's closing when you exercise, how anxiety provoking that is for people. So a lot of times when you see it happen, it looks like a panic attack. So it's something to keep in the back of your mind, but you'll absolutely see this. But wherever you land, make sure you find a speech therapist who's willing to treat this.
Awesome. Thank you. So now talking about spontaneous pneumothorax. So This can occur in anyone. I actually saw it in the ER a couple weeks ago. A 30-week pregnant patient had a spontaneous pneumothorax. So this is something that can for sure be scary and can happen. Um, we'll most commonly see it in tall, thin athletes. Anyone with any kind of connective tissue disease is at a higher risk. And obviously, anyone who's had this before is at a way higher risk as well. So they'll develop sudden unilateral chest pain. They'll have shortness of breath. Exam findings, generally, they won't have breath sounds on the affected side if they have a complete pneumothorax. You'll have hyperresonance, you'll have tachycardia, and then plus or minus hypoxia. Sometimes patients are stable enough and they have they're young and healthy and have a good other lung, so they won't develop hypoxia. But it is something to look out for. So, what is the treatment for it? Any small pneumothorax, and when I talk about small, I mean like a 2 centimeters or so, very small. Usually we just observe them and give them supplemental oxygen. Hopefully that lung will re-expand. And then any large or symptomatic pneumothorax, depending on your situation, where you are, and the stability of the patient, will either need needle decompression or a chest tube. Um, and that is something obviously you want to get them to the hospital as soon as possible if you are seeing that outside the hospital. As far as recurrent pneumothoraces, it is likely, or it is maybe not likely, but it is possible that anyone who has a spontaneous pneumothorax will have it treated and then develop another one. So typically the initial treatment for just a one-time spontaneous pneumothorax, if it is large enough to require a chest tube, will be chest tube for a few days. They'll have it removed. They'll get repeat x-rays. As long as everything looks okay, they'll be discharged. If it happens again, it is often something that needs to be discussed with cardiothoracic surgery or pulmonology to talk about pleurodesis. And what the pleurodesis procedure is they basically go in and they tack down your lung to your pleural lining. So there's ways to do it with chemicals called talc, and they actually can like surgically fix it to the uh, inner chest wall as well. So having these patients return to play can definitely be a challenge, but essentially when their lungs have fully, expanded, they fully resolved, and they have normal imaging, that is a time to kind of gradually get them back to play. And obviously, if they had surgery, making sure that their surgeon is okay with that. Respiratory infection. So this probably one of the more common things we'll see, especially in the wintertime here in Ohio. Um, so different upper respiratory infections, viral syndromes, bronchitis, pneumonia are all different things that are very common. They talk about the neck check, which is anything kind of above the neck the athletes could play. So anything that's more of a sore throat, runny nose, congestion, sneezing, that kind of stuff that they can treat with over-the-counter medications. If as long as they feel okay, they can breathe okay, they can play. Anything below the neck, so anything involving the lungs, chest congestion, real bad cough, fatigue, pneumonia, fevers, probably something that they shouldn't immediately go back and play. And especially if they're having a fever, you don't want to expose them to all their other athletes and teammates who can then get sick as well. Pericarditis, something doesn't necessarily involve the lungs, but can definitely overlap as far as symptomatology. So this is inflammation of the pericardial sac. It can be infectious, it can be autoimmune, neoplastic, or traumatic. Symptoms will have pleuritic chest pain. Classically, it'll improve when they sit up or lean forward, and they may feel a friction rub. An EKG I have on the next slide, but you'll see diffuse ST elevations with some PR depressions, and then they'll have elevation in their white blood cell count. They'll have elevation in their cardiac biomarkers, their troponin, their inflammatory markers, their ESR, CRP. Treatment is generally just NSAIDs and rest. Traditionally, colchicine has been used, but any of the NSAIDs have been studied and shown to be of benefit. Having them return to play can be difficult. This is the heart, so nothing to really, jump in and get them back to play as soon as you can. So in the FinOff book, they say 3 months after symptoms have resolved and the cardiac biomarkers normalize is when you can get them back to playing. So this is an EKG here of someone with pericarditis. You can see the diffuse ST elevations. They have some arrows here nicely pointing them out. And then PR depressions. In ABR, you'll see kind of the opposite, where you'll have a PR elevation, and that's kind of pathognomonic for it. Pulmonary embolism, another thing hopefully you don't see in your athletes, but definitely can happen. So this is a sudden blockage of the pulmonary artery. Symptoms will include pleuritic chest pain, dyspnea, tachypnea, hemoptysis, can occur like blood-tinged sputum, lower extremity edema, and tachycardia. EKG, the most common finding you'll see is tachycardia. And then you once in a while you can see the S1Q3T3 that they love to talk about, but often is not seen. Risk factors for this, any kind of clotting disorder, so your factor V Leidens, your protein CNS deficiencies, anything that predisposes a patient to clot. And then your oral contraceptives, your birth controls, recent travel. So any of our, college athletes that are on a bus frequently, going to and from different events or games, that's a risk factor. Smoking, and then any kind of recent surgery or mobilization, often something we will see as well. So something to consider. Treatment generally, depending on the mechanism of the pulmonary embolism, will be anticoagulation for 3 to 6 months or even lifetime. If it is provoked, generally, anticoagulation for a few months is okay. But if it is unprovoked or there is some kind of genetic clotting disease, sometimes they'll be on anticoagulation for life. And then returning to play, usually 2 weeks after stopping anticoagulation, will give you enough time where it is out of your system, and then you can resume playing. But obviously, that also depends on the sport you're playing as well. So the more contact sports, you're going to be definitely more careful with getting them back. So now I will kind of get into more trauma findings in sideline medicine as far as dealing with chest trauma. So key point for this, the initial assessment, sometimes you have to make a quick decision, and that is the kind of nature of the game. And then quickly being able to see, is this athlete sick or not sick? We use that terminology a lot in the ER, just helps you kind of identify, okay, this athlete is sick. I'm going to need all my resources. I'm going to need to immobilize things or mobilize things faster. If they're not sick, maybe, they can walk off the field or they're feeling okay. We have a little bit of time. And then something also to consider is that trauma evolves over time. It's not something that, well, it can be something that happens as a one-time thing, but reassessment is often critical in making sure that you're not missing anything and you're kind of seeing how things evolve. So the initial sideline assessment, this is something that you need to be very comfortable with and very familiar with. So anytime an athlete is hurt, this is something you want to kind of go through in your head. Airway, breathing, circulation, disability, exposure. So simple way to test their airway, what's your name? How are you feeling? They'll be able to talk and kind of tell you their symptoms that then you could say their airway's intact. Breathing, you'll want to listen to their breath sounds. Circulation, feel for their distal pulses. Capillary refill. Disability, this is where you want to kind of see if they can move everything, if they have any signs of a neurologic issue, if they have any weakness in a certain extremity that you're worried about a potential spinal cord issue. And then exposure. This can be challenging, especially when you're in a public setting, but exposing them enough that you can make sure you're not missing anything. So obviously, football pads can be a little challenging to get off, especially when you want to protect whether it's their spine or their head, but making sure you're not missing a back injury or something um, that that can be hidden from football pads or their clothing. Red flags. So any of these, obviously, you're gonna want to act a little faster and things that can potentially show there's a severe injury. So obviously hypoxia, altered mental status, severe pain, asymmetric breath sounds, and any kind of hemodynamic instability. I like to say vitals are vital because you need to know them and what they give you a lot of information. You can't fake vital signs. You can sometimes say, this hurts or that hurts, but you really can't fake your vital signs. So that's a good piece of information to get to kind of assess how severe the injury may be. And vital signs include a heart rate, a blood pressure, an oxygen saturation, respiratory rate, and temperature. We all saw this weekend at the marathon how important that temperature is. Maybe not in the grand scheme of trauma, but getting a temperature to kind of evaluate for, heat stroke, heat exhaustion, and next steps of care. Very important. So as far as imaging, with any kind of chest trauma, chest X-ray is going to be your and quickest test you can order, quickest thing you could get. It's often portable in the ER and urgent care, um, and it gives you a lot of information. Ultrasound, doing an EFAST. Um, this is something when I first started, covering games and working sideline. I actually asked Dr. Cup and Boswell. I said, is there an ultrasound at the NFL stadium or in the Browns training room? Is there something that we can do a fast exam for these players if they have a injury? And Dr. Boswell put it very, very nicely. He said, if you're considering doing an ultrasound for an injury, they probably need to go to the hospital anyway. It's not going to change your management. If you're suspicion for a solid organ injury, for a pneumothorax, for any kind of deep structure injury that you would potentially look for that with an ultrasound, they probably need to be on their way to the hospital no matter what. So it shouldn't delay your care by doing an ultrasound. Um, while if you have time to do it and you're waiting on EMS or something like that, it can help. But it's not something that should ever delay care, or you should make a decision. Like, if their ultrasound looks normal, you shouldn't be um, kind of okay with keeping them there. You should still get them to the hospital if you're concerned enough. And then CAT scan, CT, that's going to be the gold standard of any kind of traumatic injury to see if there's anything that needs intervened on. So this quickly is kind of what the EFAST looks like. You have all your abdominal views, right upper quadrant, left upper quadrant, pelvis, and then your cardiac and lung views. I do think looking at the lungs is probably the most beneficial, especially if you have a quick minute that you're waiting on EMS to come. It gives you a lot of information. You can see very specifically if they have a pneumothorax with an ultrasound. And also cardiac views, always good to be able to see if there is a pericardial effusion, see how the heart is beating. But this should never ever delay your care. This should never ever give you enough confidence to say there's not a deeper injury. An ultrasound shouldn't be something that keeps them away from the hospital. So rib fractures and contusions, very common in contact sports. Someone will get hit in the rib. They'll complain of localized pain, pain with deep breathing. Management for this, pain control is the most important. And that pain control will help them take a deep breath and avoid shallow breathing. Anytime someone is breathing shallowly, they can develop atelectasis or pneumonia or some other issue with their lungs afterwards. So having them on some kind of pain control, usually an anti-inflammatory or a lidocaine patch, will help them. And then incentive spirometry will also help. So forcing them to really take a big deep breath and inspire, and then getting them back to playing whenever they can breathe comfortably, they can do all their sport specific activities without having significant pain or significant shortness of breath. These are some common different paddings you'll see to protect someone if they want to play while they have some kind of rib injury. So you could see the flak jacket that can be attached to shoulder pads for football, or then even these shirts in the middle here. Some people will wear these with basketball, they'll wear them for lacrosse, they'll wear them kind of under their pads to give them just a little bit extra support. depends on their position, if they feel comfortable wearing one of these or if they feel like it limits them, but it does provide them pretty significant protection. Pulmonary contusion, another thing where someone is hit in the chest. This is bruising of the lung tissue. The key about this is it doesn't often appear immediately. It usually takes anywhere from 6 to 24 to 48 hours to show up on imaging and cause symptoms. But they'll classically get shortness of breath. They can get hypoxic, um, and they can have chest pain as well. So the key to remember for this is it can be delayed, and chest X-ray may not show it initially. So if someone has a significant enough injury, they go to the hospital, they get an initial chest X-ray, everything looks fine, but then a few hours later, they start to get very bad shortness of breath. They start to get worse. Doing a CAT scan to look and see, is this a pulmonary contusion or is this something else, is probably the next step. And having them be monitored for at least a few hours to make sure that their oxygen saturations are okay. So on the left here, you can see a chest X-ray showing this pulmonary contusion, and then on the right here, or I'm sorry, on the left, you can see the pulmonary contusion here on a CAT scan.
Joseph, and you're looking at pulmonary contusions. Did you see what the most?
I'm sorry, you cut out. I didn't hear you. Hello?
We're still here, just not Mandy.
Oh, okay. Okay. I'll keep going, and if she jumps back on, I'll answer. Um, but definitely something to think about, especially if someone's having terrible shortness of breath after their injury. As far as a traumatic pneumothorax, so very similar to just a spontaneous pneumothorax, but this comes with trauma, obviously. So it's going to be blunt or penetrating trauma to the chest. Typically, you'll have associated rib fractures on the same side as the pneumothorax. Same kind of symptoms, chest pain, shortness of breath, and then decreased breath sounds. So these are two different ultrasounds that will kind of show what a normal EFAST will look like for a pneumothorax and then what an abnormal one will look like. So this one on the left shows lung sliding here. You could see that bright white line with underneath movement. That is a normal finding, and that is a normal appearing lung. On the right here, this is an ultrasound that does not show a lung that is moving. So this would be concerned for a pneumothorax. And actually, the data has shown that an ultrasound is more sensitive to evaluate for a pneumothorax than a chest X-ray, and often something you can do faster, especially if you're in a hospital that deals with trauma frequently. So tension pneumothorax, basically a pneumothorax that you start to get into more of the severe life-threatening findings. So this will have severe respiratory distress. Hypotension is the key finding for this. That is when you can say this is now has tension physiology, and the pressure in the lungs is starting to cause hypotension and collapse of the vessels. You can get JVD, you can get tracheal deviation, but often if you see that, you're kind of well into the findings. Management, depending where you are, needle decompression or a chest tube. Needle decompression is falling a little bit out of favor, especially in the ER, because often patients will have either, large chest muscles, they'll have a body habitus where you can't reach into the lung cavity with a needle, and they will need a chest tube anyway. So if you're in an ER setting, usually we just put in a chest tube and avoid the needle. They say don't wait for imaging for a tension pneumothorax, but often you can get the imaging very quickly. So probably something you can wait for as long as they're not literally collapsing.
This is a common CAQ question. Yeah, it looks like you're about to get to what I was going to point out though. So,
Yep.
and between taking the CAQ last year and 10 years ago, they changed this. So do you want to talk about where the needle decompression site is?
Yes. So needle decompression is going to be in the anterior chest. It's going to be in the mid-clavicular line and second intercostal space, is generally what they teach us. And this needle on the right side here, so that is a device kind of made for this. It has a needle and then it has this white catheter. So will poke into the chest with the needle and catheter, and then you'll remove the needle so only the catheter is left. And you'll know you're in if you hear a big gush of air. If you don't hear that, you're probably not in the correct space. But making sure it's deep enough is the main thing you need to look out for. But like I said, sometimes patients have big, huge pec muscles, or they're larger and their body habitus doesn't allow you to get deep enough. So that is why this is kind of falling a little bit out of favor, at least when you're in an ER setting. I think EMS still uses this because they don't generally put in chest tubes. And if you're on the sideline and this is all you have, definitely something you can try.
And then Mandy's texting me. I just step away and go drag my teenager out of bed. But was she able to ask her question about when can people fly after pulmonary contusion or pneumothorax? Did she get through to you with
No,
that?
shit, I didn't hear all that.
Okay, so do you know any data about that or guidelines on when they allow people to fly? Just because that's like an issue at the professional level.
Right, for sure. I didn't see anything in the FinOff book about flying after. That is definitely something to consider though. But um, honestly, I'm not sure. I'd have to look it up. As far as specific timelines, obviously the altitude is going to be the main thing you think about. And if you are able to get them on some kind of oxygen or have it at least available, is probably something you want to consider as well. So a couple more things here, and then we'll kind of wrap up. Pericardial effusion. Hopefully, this is something you never see, but it is fluid in the pericardial sac that can develop after trauma. Could also be related to autoimmune conditions or happen after pericarditis. EKG will show low voltage or electrical alternans. Chest X-ray can show in a large cardiac silhouette. Pericardial tamponade is also something that you want to consider. This will show, or you'll have muffled heart sounds. You'll have, again, elevated JVP, and hypotension is another thing you want to be aware of for this. So anytime you have elevated pressure in the heart, it's going to cause RV collapse on the echocardiogram. And that's going to happen more during diastole, and that will cause the hypotension. So indications to get a pericardial effusion drained. Most of these will resolve on their own if they're small, but if they are large, obviously if they're causing tamponade, if patients are extremely symptomatic from it, or if you need it for diagnostic capabilities, or if it needs to give you more information. So if someone has a large pericardial effusion for no specific reason, you have to rule out malignancy, and also rule out different autoimmune conditions. So doing a pericardial synthesis and sending it to the lab to look for different malignant cells or even TB that can be of benefit. So this is an ultrasound showing a pericardial effusion. You can see the heart beating nicely here, and then around it, you can see this thick black stripe. That is all fluid that should not be there. This is an EKG of someone that you would be concerned for a pericardial effusion. You will see overall it is low voltage, meaning that these waves are not as tall as they will typically be. And then you can see electrical alternans where you will have one QRS complex that is tall, and then the next one is short, then tall, short, and it kind of alternates. So commotio cordis, something that's definitely been talked about in sports medicine recently with everything that happened with Damar Hamlin a couple of years ago. So this is sudden cardiac arrest after chest impact. It happens because of increased left ventricular pressure right after the peak of the T wave. It is caused by inappropriate ventricular repolarization because of this, and it will cause an arrhythmia most classically is VFib. So this will occur without any previous structural damage to the heart or any kind of electrical abnormality. Typically, it will be young male athletes. In sports, it would be most common to see and would be anything where there is a person or an object that can hit you directly in the chest. So football, softball, baseball, hockey, lacrosse. This is a video of the Damar Hamlin play. He's right here, I believe, number 3. Sorry, he's right there. So he got hit right in the chest. He actually got up for a few steps and then just collapsed. Obviously, that was very concerning. So they rushed onto the field, and I believe the story is they actually defibrillated him twice and did a few rounds of CPR on the field. So management for this, immediate CPR and getting an AED for defibrillation are going to be the two things that save lives. Any kind of cardiac arrest, the only two things in literature ever to be studied that save lives and decrease mortality and survival to hospital discharge are good quality CPR and defibrillation. So while everyone loves to, prioritize getting a IV and giving medications, intubating, doing all the other things, the only two things ever found to save lives are CPR and defibrillation. And the literature shows that if you wait more than 3 minutes to get the AED or to defibrillate them, there's less than a 3% survival. So survival obviously will depend on rapid defibrillation. So going back to the case I talked about initially, football player, chest impact and worsening shortness of breath. What are the next steps? So any kind of trauma on the field, you want to do your ABCDEs, assess their airway, their breathing, circulation, any kind of disability, and then expose them to look for other issues. And then if you are concerned enough getting EMS, whether they are there already, having them come over and assist you or calling them. Obviously, it's going to take a few minutes for them to get there. So thinking about that step early on is something that will help you. Getting a good set of vitals and getting the AED if you think it is necessary, putting them on supplemental oxygen, doing a needle decompression if they're unstable and not able to make it to the hospital, and then getting them to the hospital. So for this specific case, it would be, you'd be concerned most for a tension pneumothorax, someone that had chest impact, someone that's worsened, and someone that collapses. You want to think about tension pneumothorax and potentially having to do either a needle decompression or get them to the hospital for a chest tube. So overall, these are return to play guidelines for just general chest trauma and general pulmonary issues. Obviously, you want them to have their symptoms resolved. You want them to have a normal exam. You want them to gradually get back to sport. Specifically for rib fractures, when they're pain-free, they're able to breathe comfortably. They're able to do their sport-specific activities without issue. Pneumothorax, when they have resolved imaging, and again, not having any pain, breathing comfortably. Same thing for rib contusions or pulmonary contusions, normal oxygenation, normal breathing patterns, and then asthma that is controlled or any kind of acute viral illness, pneumonia, anything that they are breathing comfortably and comfortable on their medications. So key takeaways, not all wheezing is asthma. You want to think about also laryngeal obstruction. Trauma can worsen over time, and you continually need to reassess these patients and see how their symptoms are progressing, and then getting all your resources early, whether that's EMS, whether that's getting a cardiac monitor for vital signs and check a pulse ox, and seeing if you need to kind of mobilize them to the hospital sooner rather than later. Tension pneumothorax, it's going to be a clinical diagnosis that you have sometimes don't have imaging available. And then early AED always saves lives for commotio cordis or any kind of arrhythmia that you may see on the sideline. So with that, I will take any questions.
That was a good general overview. The one thing I'd make sure you're thinking about, especially in that like asthma section for CAQ, is maybe adding some stuff about um, diagnostic criteria they're into on CAQ, as well as thinking about the high level population. So for people who are participating at like the Olympic level, there's restrictions on like what medications they can and cannot take. So looking to add like that information on, what you prescribe to somebody, because you'll for sure get asked a lot. And it's different than the general population for what they're allowed to take. And Mandy's typing in the 3-minute number for AED is important to remember. That is also true. All right. Thank you for your talk. That was great.
Perfect. Thank you.
All right, everybody, have a good weekend.